I don't want to bother you with my CV. Probably the most interesting thing is that I'm the current president of the Italian Society of Orthodontics and that I don't have anything to disclose. So we can jump right into the topic of my presentation. And when I was submitting the abstract to the AAO, I thought that I would eviscerate a lot on the perfect smile, going into every little detail. But then I saw that Carol Weinstein is talking, Eric Liu is talking about perfect smiles, Ivo Marek on Monday, and I said, nope, I would change the subject a little bit. And instead of talking a lot about the perfect smile, I would like to take you on a journey with me beyond the perfect smile, beyond the social six. And therefore the outline of my presentation is going to be that we are first addressing a bit of patient expectation versus patient needs, that we'll talk about goal-oriented treatment planning, followed by efficient low-cost biomechanics. I would like to explain what we consider to be the true power of orthodontics, and of course I would leave you with some take-home messages at the end of the presentation. So of course what we have to know is, why do orthodontic patients come to see us? What do they really want? And this question was already raised by the editor emeritus of the Angle Orthodontist, Dr. Turpin, many years ago, 1993, as you can see here. And Dr. Turpin told us that the patients expect that we deliver a perfect smile to them that exudes confidence and enthusiasm, something that looks like Marilyn's smile at the end of treatment. And there's nothing new under the sun. Even today, when patients come to visit us in 2024, this is exactly what they expect: a confident and enthusiastic smile. But today, everybody wants it the easy way. A lot of publicity going on about easy smiles, simple smiles, fast smiles, either delivered with this type of appliance, clear fixed appliances, or with transparent aligners. But is the easy 6-month smile really an orthodontic leitmotif? We think that the true power of orthodontics lies far beyond the achievement of a perfect smile. What we have to do is to perform patient-centered treatment approach, focusing on dental-skeletal facial conditions, taking patient age and the correct timing into the equation. We have to think about collaboration of our patients. Cost of treatment is an important issue. And yes, of course, we have to value what our patients want. And we know that they want a perfect smile at the end of treatment. But this is just one aspect of the triad that we have to deliver. We have to combine our endeavors with good clinical expertise, and we have to add the best research evidence that is available at the moment in order to perform evidence-based practice. Or in other words, goal-oriented treatment, which is not only focusing on dental and smile aesthetics, but also on facial harmony, on achieving functional occlusion, preserving or achieving periodontal health, and last but not least, we would like to deliver a treatment result that is going to be maintainable over time. And so even if patients come to see us in the first place because they want an improvement of their smile, like Carolyn, a goal-oriented treatment approach leaves them at the end of their treatment with a result that is far beyond only having achieved a perfect smile, but having addressed all these issues in a comprehensive way. So of course we have to start beginning with the end in mind, as we have been told by Wick Alexander, which means we have to formulate our treatment objectives. And an important treatment objective, of course, is good function aesthetics, but it has to be matched with good function. Form and function should be in perfect equilibrium. Very often we are striving at achieving symmetrical results. It's a proven concept that works well in nature. And at least that's how we see it in Bolzano for a human modern being. Achieving 28 natural teeth, or finishing our treatment with 28 natural teeth, could be an interesting treatment objective, following the principle that we have to include the third molars into our treatment planning on a regular basis. So I would like you to follow me on the journey beyond these 5 perfect smiles. This is the end of the treatment of Jacob, and I hope that you will like the, let's call it perfect smile, or very nice smile at the end of treatment. Of course, it's the result of having performed a sound diagnosis, an individualized treatment plan, and having applied efficient mechanics. So this is how he came to us at the age of 14, and of course he doesn't like his smile, but we have to do more than just smile analysis. We have to perform sound diagnosis. We can see he has a retrusive chin. He has a full class 2, division 2 with arch length discrepancy, retroclined central incisors. He has low angle, and he is not only presenting a mandibular retrusion, but already the maxilla is slightly retrusive, and he has agenesis of the lower second premolars. Luckily, the third molars are all present, and this is important for us because we have to come up with the most individualized treatment plan for Jacob. So what is the individualized treatment plan for him? Well, we would like to close the spaces for the missing second premolars by mesialization of the first and the second lower molars. We do not want to extract any teeth in the upper arch because the maxilla is already slightly retrusive, which means that at the end of the treatment, the only teeth that have to be sacrificed are the upper wisdom teeth. So the objectives are symmetry and 28 natural teeth. What are the right and efficient mechanics in order to achieve this treatment goal? Are we immediately considering TADs that are so en vogue nowadays? You can hardly open a journal without finding at least 3 or 4 articles that deal with skeletal anchorage. Well, we are traditional orthodontists, and we do not consider TADs always at the first impact. We think that very often we can do more with less. This is the weapon we have in our armamentarium since almost 35 years. Uprighting springs made of stainless steel that are pre-bent by our assistants and that are then inserted into the mouth of our patients and shortened and adjusted during the course of treatment according to the requirements. Following another principle that we like a lot, also coined by Wick Alexander, the KISS principle, to keep it simple as possible. And of course, we need a little bit of collaboration from our patient side, so Jacob has to apply some class 2 elastics. And here you can see during the course of treatment that we do not need any TADs, neither do we need hemisections or corticotomies in order to improve the velocity of our treatment, but things are proceeding with normal and very traditional mechanics. We are adding always a little bit of class 1 mechanics from the lingual aspect as well. And yes, it takes some time to close these spaces, but 2 years are acceptable, I would say, for the complexity of the treatment. The beauty of the uprighting springs is that you get a very good leveling of the lower curve of Spee concomitantly with the correction or the control of the molar torque. And you can see that we were able in 24 months of treatment to mesialize the first and the second molar very nicely. They are even a little bit upright, too upright, I would say. Long distance these molars had to travel, and the only thing we have to do now is monitor the eruption of the lower third molars. We were lucky because Jacob's mandible grew favorably. This is not our merit. This was a little bit of help from above. So he finishes not only with good projection of the upper incisors that were not retroclined, but kept their position, and a good projection of the mandible due to favorable growth. And of course, we finished with a nice smile. He is very happy with the aesthetic outcome, but not only, because after 10 years in retention now, we don't have only to report that the smile aesthetics are maintained, but we have an intraoral situation that is very maintained as well. And we finished with 28 natural teeth because, as you can see, the lower wisdom teeth have erupted very nicely. We finished with a perfect class 1 occlusion on the canine aspect and full class 3 molar-wise. What is the story behind the second, let's call it, perfect smile? Well, unfortunately in Italy we still have a caries problem. Relatively many school children still present with caries, so no wonder that we have a lot of patients that come to see us with early loss of first or second molars. And this was the case in Hannes. So he presents not only with a retrusive mandible, as you can see here, but with a class 2 subdivision, so full class 2 on the right side due to migration of the lower dentition because of early loss of this first molar in the fourth quadrant. Perfect class 1 on the left side. There's a midline deviation. He has a little bit of retrusion of the mandible, as you can see here, and some sort of additional skeletal asymmetry as well. We're very lucky because in the fourth quadrant, the third molar is present. And now I give you a little bit of time, just as Jay did, 5 seconds to think what your treatment approach for Hannes would be. Jay probably would think about placing some TADs in order to mesialize the molars in the fourth quadrant. We think that probably diagnosis first is the right way forward in order to come up with a maximally individualized treatment plan and using efficient biomechanics. So let's take a close look at his smile, and we can see that the upper midline is very much deviated to the left side, while the lower midline is just a little bit off to the right. And we can see that there's a cant of the occlusal plane. And if we take all these issues into the consideration, there's no need for TADs. But there's a lot of need for unilateral heavy class 2 elastics, a little bit of collaboration from on the side. And even professionals that are used to insert a lot of skeletal anchorage devices like Birte and Björn, they say, yeah, sometimes we don't need them, but probably we need a little more brain instead of high technology to pick the most appropriate treatment solution for our patients. So this is the biomechanics here for Hannes. You can see again some uprighting mechanism in the lower arch, this time a burstone base arch, which is more or less the same thing as the uprighting springs, very low-key biomechanics, but admittedly collaboration from Hannes' side in order to mesialize the molars in the fourth quadrant. And you can see that obviously has worked. So we got rid of the class 2 on the right side. We have now at the end of treatment perfect class 1 relationships. You can see that the molars came very nicely forward and that the third molar is now substituting the mesialized second molar in the fourth quadrant. We got rid of the cant of the occlusal plane due to the intensive wear of the class 2 elastics on the right side. And you can see that the mesialization took place in a parallel manner and that we have not jeopardized the dentition in terms of creating root resorptions. And of course, the end of the treatment is a nice smile. This is what our patients expect, but not only, because we have saved him from an intense implantologic prosthodontic replacement of the missing first molar. Third, smile at the end of treatment. Looks nice, I would say. This is Valeria. She came to us, of course, for smile improvement, but not only. She has some lip incompetence, as you can see. This is the intraoral situation that she presented when she came to see us. A little bit of arch length discrepancy, especially in the lower arch. But this is not going to be the situation we have to treat because, unfortunately, because of an endo problem, she is going to lose the first molar in the first quadrant. And again, we have to do a diagnosis first. We have to think what the best treatment mechanics might be for her. So are we considering to place some TADs in order to mesialize the second and the third molar in the first quadrant? Well, it depends. It depends on the diagnosis, depends on the patient. Of course, we have to perform a thorough diagnosis, not only evaluating the smile, but going through all the aspects that have to be comprehensively addressed. And we have to use a little bit of brain, and it's very helpful to read these classic articles by Tom Mulligan and Charlie Burstone, because they are immensely helpful in order to find the right way forward, which is not necessarily to place a TAD in every patient that needs mesialization of the dentition. Same thing in Valeria. These were the times of COVID where everybody wore a mask. So we were sitting together with her, we were discussing the treatment options and the right mechanics, and she said, I don't care about wearing some intermaxillary elastics. And therefore, again, as you can see here, very traditional uprighting springs, class 1 elastics from the vestibular and from the lingual aspect, helped by class 3 elastics, which the patient had to apply. And you can see that in 17 months of treatment, which is acceptable, I would say, for that entity of the problem, we were able to remove the appliances. We finished with good interincisal and canine contact, which is mandatory for maintainability of our treatment results. And you can see that we didn't lose the inclination of the upper incisors, and we were able to mesialize the second and the third molar in the first quadrant very nicely with this very traditional low-key mechanics. So this is before and after. We have a good occlusion. We have mesialized the second and the third molar in the first quadrant. We have centered the midlines. Of course, we have achieved a better smile. We have even reduced the gummy smile, as you can see, due to the uprighting springs, which were helpful for a little bit of intrusion. And probably she has also learned to smile a little differently because she's more confident with her smile. And this is what we realize in many patients, that when they are confident with their smile, they change the dynamics of their lips. So apart from having, of course, created again a much nicer smile, we have also resolved this relevant issue of preventing an implant-borne crown for her. Fourth smile. End of treatment. Obviously, our patient is happy because there's a lot of red lipstick. What is the story? This is Manuela. Manuela came to see us in 2013. She has a class 1 profile. She's not interested at that time in any improvement of her smile. What she cares about is the lost second molar in the first quadrant. You can see she has a perfect class 1, a little bit of crowding in the lower arch probably. She's not interested in smile improvement, so we, of course, have to take what our patients want into the equation. The request, her special request, is an invisible unilateral space closure with the only aim to avoid the implant substituting the second molar. The individualized treatment plan for her, therefore, is, this time, believe it or not, TATS. This, at this stage of treatment, seemed to us to be an efficient, low-cost treatment mechanics in order to do exactly what the patient wanted from us, avoid the implant. 2 TATs, 2 brackets, 2 power chains that are changed every 5 weeks, and after 9 months we have achieved our treatment result. That was in 2013, when Manuela was not interested in any smile improvement. But we all know that people change their minds, so 3 years later she's back, not really happy with her smile, and said, I want to improve that. She has very short teeth, as you can see, very mild malocclusion. And of course, today with digital smile design, we are able to communicate very nicely with the patients. We might be able to be more meticulous in our treatment planning than we had before these digital interventions were possible. And then we can select the most individual treatment plan for Manuela. So we have to create some space in order for the restorative dentist to lengthen the clinical crowns. And as this malocclusion is really very minor, of course, we can do this with clear aligners nowadays. But again, we need a little bit of collaboration from Manuela's side, so intermaxillary elastics are necessary in order to finish with a really nice treatment result, not only aesthetically, but also occlusally. And here you can see the end of the story. And of course, this is now a perfect smile. She's very happy with the outcome. But we did a lot more with this 2-stage treatment approach. We saved her, again, from an implant-borne crown replacing the upper second molar. And this is the pre-last smile I would like to discuss with you. End of treatment for Amy. Amy came to see us at age 21, as you can see, with these ectopic Jayiba canines. And of course, we know from David Turpin that she wants a nicer smile. But first, we need a correct diagnosis. So we have to take a close look at the dentition, at the occlusion, and we can see that there's a full left class 2, there's a midline deviation, and of course there's arch length discrepancy, as you can see. She has some sort of bialveolar protrusion, and like the other patients I have shown you, she's missing a molar. She's missing the lower left first molar. And again, it's our duty to come up with the most individual treatment plan for this special situation. You can see that all first molars are not in very good shape, so it's a relatively simple decision to compensatorily extract the first molars. But then we have to think, what are the most efficient biomechanics for her? Common sense mechanics, uprighting springs. We had the great fortune to be, I would say, very good friends with Tom Mulligan. As you can see here, he's with us at an ankle meeting. So these common sense mechanics are very helpful, even for situations where teeth have to travel a long way. And you can see that we are starting with these uprighting springs from the first day when we place the round super-elastic wires. We immediately start with these uprighting springs, the closure of the spaces from day one. And you can see what we are doing on a regular basis. We are not bonding everything that is white. Why not? Because we don't want to add more discomfort to our patient as necessary. This statement, or this very smart advice to not bond everything that is white, has been coined by one of the icons in orthodontics, and probably the younger generation here in the audience might not associate a name to this face, which would be a pity, because we're dealing here with the great Robert Ricketts, who very smartly said, don't bond everything that is white, make first the space, and then you can include the teeth into your appliance. So here you see these uprighting springs, really very low profile biomechanics, but very efficient in order to close the spaces. We need a little bit of collaboration from Amy's side to get rid of the class 2 on the left side, as you can see here. But with these very low-key biomechanics, we are able to close the spaces both in the upper and in the lower arch, as you see here. We're not perfect, so rebracketing is necessary before we remove our appliances, because we are aiming at the best treatment result we can possibly achieve. And here she is after appliance removal. Of course, she's happy with that. Let's call it perfect smile. There's a good projection of the smile, good projection of the incisors, but far over the perfect smile, we have done a great service for her. We would say we have achieved good class 1 on the right side, and on the left side as well. We have centered the midlines, and you can see that we have not jeopardized the inclination of the upper and lower incisors. We have established a good inclination, have not ruined the profile. We were able to mesialize the teeth very nicely and parallelly. We have to make sure now that the wisdom teeth are going to erupt, but they are in a favorable position. And if we are really picky with our result, we can do a little bit of finishing, taking a closer look at what we have achieved by now. So the closer look reveals that probably a little bit of gingivectomy is necessary in order to create the same length of the lateral incisors, and that a little bit, I would say 2 composite restorations would be the kick to optimize the treatment result. And yes, this makes a difference, these little touch-ups in the beauty of the final result. And of course, a massive change for the aesthetic outcome here and for the well-being of our patient. But far more, we have achieved a very nice occlusion. We have thought beyond the perfect smile in order to achieve a real great result. So all nice stories, but what else could I add to be a little provocative in order to finish this presentation with some more food for thought? Well, there's always another side of the story, and the other side of the story here is represented by Kevin. At the end of treatment, this is his final smile, and you might say, well, that doesn't look so perfect. What is she trying to sell here to us? Well, everybody has a very individual story. This is Kevin, who came to us at age 27, and obviously he has been relatively negligent with his mouth. So this is how he presents, and there's a class 2, there's a deficient chin, there's lip incompetence, and we have to perform a thorough diagnosis before we start his treatment. You can see a lot of arch length discrepancy, you can see increased upper and lower curve of spee, you can see a midline deviation. There's a class 2 skeletal component as well, he's high angle, and like all the other patients, he is missing a molar due to caries. Give you, again, 5 seconds to make up your own treatment plan. That should be very individual. individual, like creating a pair of bespoke shoes by this famous shoemaker from London, John Lobb. We have to define the treatment objectives, and we would like to finish with symmetry and 28 natural teeth, as I've told you. But here, some more out-of-the-box thinking is required. What is out-of-the-box thinking here? Well, let's take a closer look. What do we advocate? Of course, we have to create a symmetrical result. The first molars are in bad shape, so it's not a difficult decision to extract them. But you can see that we have to focus on another additional little issue after the end of treatment. This is this impacted third molar. What are we going to do? Same as we've done in the other patients. We extract the 3 molars, and then we don't bond everything that is white, adhering to this principle by Robert Ricketts. Efficient biomechanics for us since 35 years are always these uprighting springs that are so super efficient, and that doesn't cost anything. And again, you can see here from the first day on, from the first round wire, we are applying these uprighting springs, and we start space closure right away from the lingual and from the vestibular aspect. We are monitoring, of course, the migration of the teeth, and you can see that we are just adding the brackets on the aesthetic zone once we have created sufficient space, because we don't like the round-tripping effect. So, of course, we are trying to use our brain when we are treating the patients in the most efficient way. We're coming to the end of treatment, and of course, again, rebracketing is necessary. We have to be autocritical in order to come to the best possible treatment outcome possible. And here you can see, after rebracketing and after the finishing procedures, we are almost close to removing the appliances. And here he is now after the removal of most of his appliance. We have maintained a good inclination of the upper and lower incisors, but we still have this problem of the impacted, horizontally impacted third molar. And are we thinking about TADS this time? Jay has shown us a very nice treatment of an impacted third molar, where he has used TADS for uprighting. Well, we are the traditional couple in Bolzano, so of course we need surgical exposure of the tooth, but then we thought that with very traditional open coil springs, a little bit of bracket replacement, but that would have been also necessary in case of using TAD for uprighting, we were able to recuperate this third molar. And you can see that all during the uprighting period, Kevin didn't have any brackets on the aesthetic exposed teeth. So this is the end of the story. Hope you like what you see. We have achieved good parallelism of the teeth. We have closed these large extraction spaces in a nice way. This is the before and after. This is his smile, before and after. Projection of the incisors, projection of his smile. And some of you might now say, well, this is not really convincing. This is not a perfect smile. What is she talking about? Well, of course, had Kevin enough money, he could now go to the restorative dentist, and the restorative dentist has the power to place some ultra-thin disilicate or feldspatic veneers on that dentition to add, I would say, the icing on the cake. But this is the prosthodontic superpower. This has nothing to do with our orthodontic superpower. So we should not adorn ourselves with borrowed plumes, I would say, but concentrate on our power, on the power of orthodontics. And I think the real power of orthodontics is not creating a perfect smile. It's the possibility to change a totally deteriorated dentition to achieve a healthy, functional, and maintainable dentition over time, which makes us part of the medical discipline again. So, of course, had he the financial possibilities to add some disilicate veneers or feldspatic veneers to this result, it would be the icing on the cake. But the big job is done by our orthodontic treatment. And therefore, the take-home message today would be that I guess that the true power of orthodontics really is beyond achieving just a perfect smile. It's true what Lyle Johnson says, that orthodontics is going to become a multi-level calling. We'll have at the basis of this pyramid the people that just want a perfect smile, that just want a social six aesthetics, what I call cosmetology. They are clicking on the button of easy, and then Birte is unfortunately right that she considers these orthodontists close to hairstylists and far away from providing a medical treatment to the patients. But there is more to a smile. At least we think there's more to a smile. A truckload more, which means that many patients nowadays, they are at the top of the pyramid and they need evidence-based practice, especially the patients that had an orthodontic treatment before and are not satisfied with the results. And in these patients, we have to perform a differential diagnosis made with an understanding of the dimension of the dentition, and that is then the key to evidence-based practice. And this is the last example. This is Martina coming to us after an orthodontic treatment that obviously had failed. She's not happy. And of course, we have to perform a very thorough diagnosis. We have to evaluate every little detail in order to value what our patients want. And they want that perfect smile. That's a perfect smile that they wanted 30 years ago, and that is still so important today. But apart from just creating the perfect smile, we have to be maximally individual, and we have to think sometimes out of the box. And in her case, because we wanted to finish with a really impeccable treatment result, we did something we have done probably twice in our career after having treated more than 35,000 patients. We unilaterally extracted a first premolar on the right side, because we were aiming not only at a perfect smile, but at a treatment result that can be considered a little piece of orthodontic art and science. And speaking about art and speaking about seeing beyond certain topics, I would like to welcome you in Florence. This year, the Italian Society of Orthodontists has the conference, the international conference from the 17th to the 19th October in the beautiful city of Florence, where we would like to build bridges with the world. We have very interesting topics that are going to be addressed. We will talk about interdisciplinary treatment, the quest for excellence. We're going to focus on the future in orthodontics, and for the first time we are going to add a little pink touch to the program with a session with only female speakers on the podium. So I would really like you to pack your suitcases and come to Florence in October. And with that, I thank you very much for your kind attention. And of course, you have to evaluate my presentation, and please be kind.